So first things first, after we conclude chapter 10, that ends this section of information, meaning next Tuesday is going to be our next test in here, test number 3, which will cover chapters 6, 7, and 10, the one we're going to do today. Also, there is a homework assignment due that day as well, so please don't forget. That's next week, and I can't believe I'm saying November the 4th, a week from today, so just a reminder. Any questions before we get started on that? Looking at my calendar, it looks like, not including today, but there's only 3 more times we have to be in here on a Tuesday. There is a holiday. There is our quote-unquote open day leading into Thanksgiving. So there's not including today. Next week there's a test. There's Veterans Day the week after. The week after that, which is November 18th, we'll do chapter 11. The week after that is the open week leading into Thanksgiving, and then the week after that, December 2nd, is the final exam. So this semester is flying by very, very quickly. Again, since this class only meets once a week, it even seems shorter, at least when I look at it. I don't know how you feel, that we only have, not including today, but 3 more times to be here. And of those, 2 of those times, you're going to be taking a test. So I know that's probably not exciting. But anyways, let's go ahead and knock out chapter 10, all about chest imaging. So X-rays, that's what we're talking about here when it comes to chest imaging. So this is just a really superficial overview of imaging. We're not training to be radiologists. If not, we would have been in a different school, in a different program, getting ready to sit down for the next 6 years and study all this stuff. So this is a very superficial overview of X-rays. We will be expected to look at X-rays, do some basic interpretation of the X-ray. They're board exam questions where they actually give you an image to sit there and look at and be able to interpret. And so they're important. We're going to be asked to know this stuff. So X-rays have been around. You may be surprised to note the date. That is not a typo. That is 1895 when the X-ray was first created. Aside from the stethoscope, who created the stethoscope?
Oh, man.
Lennox, very good. René Lennox. Oh, I didn't know this was going to be a question. René Lennox created the stethoscope. So aside from that diagnostic tool, this was the next diagnostic tool that was created, the X-ray. Willem Roentgen is the one who was credited with that. The X-ray will go through the patient, and depending on absorption, it will put forth an image on a film cassette. Now, X-rays have evolved a lot since then, and it wasn't that long ago. And I say it wasn't that long ago because I remember when we looked at films, and we would have to have a film that we would have to put up against a light background to see, or we'd hold it up to the light in the room. Now, of course, everything is digital, and so we get results very quickly, seeing the digital results on a computer terminal or computer monitor. Now, X-rays will penetrate matter, or matter, I should say, will penetrate, or the X-ray will penetrate matter. There's some things that have lots of penetration, some things that have very little penetration, whether it's looking at air or bone or tissue. The terms here, so be very clear that you understand the terms. The term radio opaque, the image will appear light or white in appearance. Now, things that appear light or white in appearance, I will say, is not air. Air appears darker in color. So if you're seeing something that's white or a light, hazy white, it could be bone, it could be tissue, it could be fluid. But what is it not? It's not going to be air. Now, air will appear radiolucent. Again, indicating it's darker in color. The air-filled lung does minimal absorption of the X-ray, and so it will appear dark, black in color. But if we say, well, what's probably one of the biggest issues here with an X-ray is an X-ray is showing a 2-dimensional image of a 3-dimensional object. And so it's not perfect by any means, but it does give us a nice baseline, does give us some good information. We'll talk about some other type of imaging a little bit later, when we can maybe see something abnormal on a standard chest x-ray that then may be suspicious and requires higher level imaging. And that, of course, can occur, and we'll talk a little bit about that today. All right, so what's the importance of the x-ray? Detecting alterations of the lung caused by different processes, disease processes that could affect the lung itself. If we are giving a patient some sort of therapy, we can do a follow-up x-ray to see if the therapy is working. Is it doing what it's supposed to be doing? We've talked about looking at using the x-ray post-intubation to make sure the tube is in the right spot. It's not too close to the carina, nor is it too far out away from the carina. We could see changes in lung disease. So our patients with chronic lung disease, we could see images or x-rays taken over several years, maybe even several x-rays taken over the last couple of decades to see disease processes worsening or maybe disease processes improving. After invasive procedures, and when we use the term invasive, what does that mean, invasive?
Anything that breaks the skin.
Breaks the skin, goes inside the body. We can see some things post-procedure. For example, there's procedures that do require a needle to get placed into the chest. Well, what's a concern with the lung with a needle penetrating, God bless you, into the chest? Maybe it nicks the lung, maybe it causes a pneumothorax. So post-procedures, many times they'll do an x-ray just to make sure a pneumothorax didn't happen. One thing we should always understand too, if things are emergent, there's things that are happening very, very quickly, there's no reason to stick around and wait for the x-ray. If we can foretell something bad is about to happen, no sense waiting around for an x-ray. Go ahead and take care of what we know the problem is. The x-ray result will come in due time, but God bless you, don't wait around for the x-ray. If something is emergent, let's try to treat it or take care of it. We don't have time, again, if it's something emergent, to wait just for the x-ray. All right, let's talk about some of the different imaging and imaging positioning for the patient. All right, the first one, farthest away from me to your left, the PA, or posterior anterior film. The film cassette, which will absorb the x-ray beam, is in front of the patient's chest. Okay, so that cassette will be in front of the patient's chest. The x-ray beam will be shot from behind the patient. So you can see how she is positioned with her chest up to that film. The x-ray machine is behind her, shining through to the cassette that's in front of her chest. That's a PA film. That is the standard. That is the primary method to get an x-ray. Has the best clarity. It minimizes magnification of the heart. Okay. Other imaging, like what I'm about to talk about here, an AP film, the heart can appear larger in size. And it does make differences the size of the heart. There could be a cardiac condition that causes enlargement of the heart. And if we misinterpret looking at the size of the heart, you can misinterpret a diagnosis. Okay, so if you or I needed an x-ray right now, a chest x-ray, they would send us to have a PA film. We're capable of walking into that hospital, we're capable of walking into that department, going to the radiology department, and getting that image done. Now, for us as respiratory therapists, we have a lot of our patients who require mechanical ventilation. They're pretty sick, they're on the ventilators, they're lying in bed, they can't physically walk to the radiology department, they can't physically stand up in front of that x-ray or that film cassette image to have an x-ray done. So what does the x-ray department do? They go to the patient. What we would simply call a portable x-ray. Now that x-ray image is known as an AP film, anterior posterior film. Where's the x-ray beam? It's shining in front of the patient. Where's the cassette? Behind the patient's back. When you get some time, and you guys we'll spend some time in the ICU with a mechanically ventilated patient, you will see when x-ray comes in to do their imaging, They take that patient, they pull them forward. Again, remember, many of our vent patients are not capable of doing a whole lot of moving on their own. They'll pull that patient forward, jam that cassette behind the patient's back, and shoot the image from the front. Once they get done shooting the image, they get that cassette and take it back with them to be processed. All right, so this is the portable film. I say interpretation can be challenging because, again, cardiac size tends to be a little bit larger with an AP film, plus the patient may or may not be in the best position. Picture it's a vent patient. They're comatose. They put the x-ray film behind the patient's back. Is the patient going to be perfectly centered? They try to get the patient perfectly centered, but sometimes those patients are slouched, sometimes they're rotated, sometimes they're leaning slightly forward, which makes the interpretation sometimes a little bit challenging, a little bit difficult, because the patient's position is not as perfect as it would be with a PA film. All right, some others. Lateral. Image where the patient is turned to the side. This gentleman with his left side pointed at the film, there's a left lateral. Turn them over, could be the right lateral. Again, depending what you're looking for. Lateral decubitus. Patients lying on their side and the image is being shown through. Now, when we do lateral decubitus x-rays or look at these lateral decubitus x-rays, what we're looking for is fluid. Again, think about if there's fluid, extra fluid in your lungs. If you're turning to your side and lying down, what's going to happen to that fluid? It's going to layer out because of gravity. And so you can definitely see a difference between if they're standing upright, a PA or AP film, versus lying on their side. That fluid will follow gravity. I don't have a picture here, but you can go ahead and just assume an expiratory view. Now, most of the time, a chest x-ray is performed during a deep inspiratory effort. You'll hear the x-ray tech say, okay, take a big deep breath and hold it, because they're wanting to get the image when the patient has the most possible air in their chest. Just an aside, it always makes me laugh when the patient's on a vent, kind of comatose state, and the x-ray tech still says, take a deep breath and hold it. Patient can't hear you. They're not paying attention. They're not following your instructions. If you really want them to take a deep breath and hold it, you should get us involved. They're on a ventilator. I can make them breathe how I want them to breathe. I can make them take a big deep breath, and I can make them hold it. But they don't. They tell you, deep breath and hold it, click, shooting, and they'll take that in.
It's like when you take them to CT and you have like the button like, breathe in,
Right,
hold your
right,
breath.
right. But an expiratory film, unique situation to ask for an expiratory chest x-ray. If you actually have a patient perform an expiratory chest x-ray, they tend to be looking for a pneumothorax, a small pneumothorax. Now, generally with an inspiratory film, they should be able to see a pneumothorax pretty well. But if it's small, sometimes it's difficult to see the pneumo. Again, everybody remember what a pneumo is, right? Air trapped in the pleural space. On a standard AP or PA film, pneumo is pretty obvious, but if the pneumo is small, it may be hard to identify. If you have the patient perform an expiratory film, okay, so they completely exhale, again, exhaling most of the volume from the chest. Now, if that was me or you, and you looked at your expiratory film compared to your inspiratory film, if I just showed you your expiratory film, you think, what's wrong with me? Where's all the air? Well, remember, you exhaled. Now, if a patient has a small pneumo or even a standard pneumo, when they exhale, guess what they can't exhale? The air that's a pneumo. And so it will still appear on an expiratory film, where the rest of the lung actually looks empty because the patient did exhale their breath. So again, could help identify, and I would say, a small pneumo. A pneumo that's kind of, on the inspiratory film, they can't really tell perfectly. You know, I think there's a pneumo, there could be a pneumo there, but let's do an expiratory film just to see.
Sure. So what would that look like on that chest? Was that just be like a dark circle, or?
Yeah, we're getting there. We're getting there.
I'll hold my horses.
It's good. All right, so looking at the x-ray. All right, x-rays shouldn't be just judged based on the x-ray alone. There should always be other follow-up factors that we're looking at. There's parts of the story we should know before we look at the x-ray to say, I think I see what's wrong here. So that's why I say, but should be interpreted in the context of other clinical information. Looking at each area systematically so we don't overlook or miss anything. The spinous processes of the vertebrae, if you can tell here. Does this patient look pretty straight on to you? Okay, looks pretty good. You can see the spinous process. You can even look at the clavicles. The clavicles should be even. Picture, I know you can't see my clavicles, but picture where my clavicles are. If I'm all turned funky to the side, notice how my clavicles would be kind of all offset. Or if I'm rotated, how my clavicles would look. This patient looks pretty good. The image looks pretty good straight on. As opposed to this image, now the yellow and the red is not normally there. It's there to kind of emphasize what we're seeing. But here a patient is slightly rotated. Okay, slightly rotated to their right. You can see the clavicles are a little off. You can see the spinous processes off center just a little bit. So this patient is slightly rotated some. We talked about x-rays and its penetration of air or bone or tissue, etc. Again, the lung has a very low density, doesn't really absorb much of the x-ray, so it will appear darker in color. And what's that word? Radiolucent, as opposed to more dense particles like bone would be more radio-opaque, kind of that whiter appearance. The lung, even though it's air-filled, and the lung will appear dark in color, it's not going to be perfectly jet black like my desk up here, the computer. You're still going to see stuff inside of it. So what I mean by kind of peppered with, and I should say kind of white dots or lines, you should see some color in there. Again, it shouldn't be all over the place, because if it's all over the place, then I would say it's more consolidation or more radio opaque. But it should have some specks of white in it. And what is that? That's the blood. Isn't there blood moving through our lungs as well? So that will appear. And that's what I mean by kind of peppered throughout the lung field. If I don't see that, then maybe what I'm looking at is strictly air, and that could be the pneumo. And we'll see some good examples of a pneumo in just a second.
Can you go back to the
No. Yeah, go ahead.
I'm just trying to point out the tracheal shadow. Is that black, like that kind of like that?
This
Okay.
one is kind of hard to see. Sometimes on these projections, it's very hard to see. I'm going to trace it because I can see it better here in front of me.
Yeah, I see. Yeah.
You know, sorry. There's the left. There's the carina.
Okay, I see it. Yeah.
There's the right. There's the left.
So as long as the spine's perfectly aligned with that shadow, then you can.
You know, the patient is straight on.
Yeah. Okay.
As opposed to this one where they are slightly rotated. And that's, to be honest, that's not the worst rotation. You're going to see some that are a lot worse than this.
So would they be rotated to the left?
In this example, they're rotated more to the right.
Then you have to retake more.
Like I said, this is not the worst image in the world. There's going to be some that are worse, and if it's, and we need a better film. They will ask for another one. Again, that's not us to take the x-ray, that's the radiologist, or radiology techs. So consolidation will appear white, patchy white. That could be an indication for a pneumonia. You know, the pneumonia that's there could be a tumor in there. We can see tumors on x-ray. Even if the alveoli are collapsed, so now it's just tissue, lung parenchymal tissue, that will appear white in color. Again, not air-filled tissue, so the lungs are collapsed. Greatest density, of course, is bones, but don't forget tissue, fluid, they carry more density than air, but bones definitely. Foreign particles, inhaled foreign material could appear more dense on x-rays, but there's also some things that, for example, a patient could aspirate that might not show up on x-ray. And so, again, things we'll look at in due time. All right, I mentioned when a standard chest x-ray is done, should be done during inspiration. Good inspiratory effort with at least 10 ribs being shown. That way you know it's a good inspiratory effort. The silhouette sign. Again, I don't know how this will project here, but the silhouette sign. Sometimes you can see multiple images overlapping where it's just not a continuous white area. Let me give you the picture so you can see it. Everybody see the heart, right? Everybody see the heart? Can you see the diaphragm? Notice especially here, you can see the different densities of two different structures. They're just not all merged into one just giant white area. So it's the silhouette sign. You can see different separations between what's heart, what's diaphragm. Air bronchograms. Now that's something unique. Sometimes you can see on an x-ray an air bronchogram. This is when the bronchi are surrounded by consolidated alveoli. Now consolidation is just a fancy word for something in there like a pneumonia. Again, something that would appear more white in color. So the air bronchogram, and I know it's very hard to see. See, notice this whiter area here?
Yeah.
And if you really look close, you can see this kind of line of air in there. My next image actually is a little bit better, but you won't see the next image on the x-ray. You would see after somebody's doctored the x-ray to really make the air bronchogram stand out. Okay? So this is the same image. So let me back up one. But that's what you would see. That's what you would see on the x-ray. Okay? This abnormal area here, clearly there's some consolidation, there's some white haziness. But if I go to that next image, you can see where the air bronchogram is. You can see some other areas. This is air right next to consolidated lung. Okay, so the air part, the air passage anyways, really stands out. They refer to this as an air bronchogram. In this example, this is probably a massive pneumonia that the patient has, and these pockets of air that are within the bronchi, within the airway, that are standing out on the image. Again, when it's when the x-ray is doctored like it is here for you guys, you really can see it. But if this is how the image is going to appear in the chart, in the computer, on the image that we put up on the x-ray board, it's very difficult to see. Very difficult to see. But I just want you to be familiar with the term air bronchogram. And I did give you this one, didn't I? Okay. You know me, sometimes I'm not going to give them this, I'll give them this one, but not this one. But you really honestly need that to really be able to see the bronchogram.
But that's a regular x-ray that they do this analysis, or?
What, this?
Yeah.
This one that's like is doctored?
Yeah, they just
yes,
get
it's
a
strictly
regular-
for,
Okay.
this is what it's going to look like.
Okay.
Okay, for you guys, it was doctored a little bit to make it kind of stand out so you can see it. Okay, that's not how it's not going to appear this way on the x-ray. I wish it did. I wish it would. And I bet you there's technology and ways to do it, but what you're going to see is that image. And again, extremely hard to identify. But that's why they pay their radiologists the big bucks, right? To have to interpret that. All right, clinical and radiographic findings in lung disease. Now, I'm not covering every single x-ray in the chapter, dealing with every single disease that is mentioned in the chapter, because we have a whole class next semester called pulmonary pathology, where we're going to talk about all the different diseases, and part of the information of all those different diseases is the x-ray, and what's unique about the x-ray for someone with that disease or that condition. But I am going to hit several of them that's listed here in the chapter. So the first thing, atelectasis. We already know what atelectasis by definition means. Collapse of the alveoli, collapse of the lung. And how do you think the x-ray would appear if the lung is collapsed, meaning there's no air left in there? You know, what color would it appear? White, but, and again, white, but what's the fancy medical word? Radio opaque. So be prepared when I test you. I am not going to use the word white. I'm going to call it what again? Radio opaque. Radio opaque, indicating it's what color? White. I am not going to say the X-ray looks extra dark or extra black. I'm going to say what? Radiolucent. Radiolucent. So be comfortable using that terminology. Now, if the atelectasis is significant enough, okay, so I'm meaning significant collapse of the lung, it can move the mediastinum, the middle portion, which includes the trachea, which can include the heart. It could pull the mediastinum and all those associated areas toward the area of atelectasis. Okay? If the atelectasis is significant enough, if it's large enough, it will pull everything that's supposed to be in the middle, trachea, heart, it will pull that stuff toward the area of collapse, the area of atelectasis. So in this example, where's the radio opaqueness or opacification? Obviously, it's the patient's right side. This is, and again, would you say it's the right middle lobe, right upper lobe, right lower lobe that's atelectatic? No, it's the whole damn thing, right? Whole damn thing is collapsed. And what happened, again, it's hard to see the trachea, but you can. There's the trachea. Dang, that's what I'm saying. And isn't the heart supposed to be over here somewhere?
Yeah.
Where's the heart? Where'd it go? Been pulled where the area of atelectasis is. Okay? So this is complete collapse of the right lung. Now what caused it in this patient's case, if I had to guess, and I don't know the reason why, but if I had to guess, it could have been a massive mucus plug in the right main stem. And so none of the air can get into that right side because of a massive mucus plug. Okay? As it continues to collapse and get worse and worse, it starts to pull everything toward itself. Pneumothorax. So air that's in the pleural space. Okay, so air continues to build up in the pleural space. Whether it's from something on the outside like a stabbing or a bullet, or maybe something from the inside that the lung just ruptured and now air is leaking into that pleural space. So for whatever reason, air is filling the pleural space. These little black arrows are supposed to represent or show where the lung, the actual functional part of the lung actually is. Meaning all this area out here is air. Air in the pleural space. I think I have several here. So yeah, you can really see the shape. You can really see the outline of the lung itself, the functional part of the lung. And when I say functional, I mean the part that does gas exchange. How about this one? That's the outline of the lung, meaning all this other stuff out here is air that's trapped in the pleural space. Now, when the air builds up enough on the affected side, what could it do to the mediastinum, the trachea, the heart? It's not going to push it toward itself like atelectasis. It will push it away. Push it away. Again, the more and more air that fills that pleural space, the pressure builds up on this side. It pushes everything away. What do we call that type of pneumo? Where it's really, really bad? Tension pneumothorax. So with the tension pneumo, you typically would see the trachea shifting away from the pneumo. Again, there's other things that are occurring with the tension pneumo. There's cardiovascular collapse, hemodynamic collapse. So you would see issues with their EKG, their heart rate, blood pressure, etc. God bless you. As it got really quiet. All right, so normally an air-filled lung, I use that term peppered, right? Peppered with dots and lines, again, because there's vasculature there. Do you see the dots and lines on this side? All of the, yeah, not even ribs. Yeah, either they were taken away or something really is wrong here. All this is air from a massive pneumothorax. Can you see the trachea?
Yeah.
The heart even pushed further away here. Again, massive pneumothorax on this side. And again, pushing everything away. Here, I'm going to trace the trachea because again, I can see it much better here on my image. There's the trachea, there's the carina, there's the left main stem.
So the right main stem is basically going straight down.
Yeah, it looks like it's going straight down, yes. And there's the left. But again, everything's being pushed away from the pneumothorax. Remember, atelectasis pulls it toward the atelectasis, and pneumothorax pushes it away, or pushes it away from the pneumo. Now, hyperinflation. Don't confuse just simple hyperinflation with the pneumothorax. Hyperinflation means there is extra air present, but not extra air necessarily in the pleural space. This is extra air actually in the lung itself. And we definitely have that patient population that I'm refusing to say their initials, but you know who I'm talking about, that definitely have hyperinflation, extra air that they struggle to get out. That's why their chest is what shape? Barrel-shaped chest, because they have an increased anterior posterior diameter. You can see on this lateral image how wide it is. It's hard to see here, but the ribs that are normally kind of curved downward really almost straighten up because there's so much extra air inside their chest. And again, it's from the disease, it's from the illness, whether it's the COPD or emphysema component here, all that extra air that they struggle to get out with. Could even flatten the diaphragms, could push the diaphragms down. Again, all of this, quote unquote, extra air. When I said COPD, I said emphysema, possible asthma. Again, severe asthmatic who's trapping air could appear this way. And I know we haven't talked a whole lot about asthma yet, but one thing I would say, asthma when it comes to hyperinflation, only during the asthma attack. Because the asthma patient, when they don't have bronchospasm, their x-ray would look just like mine, just like yours. No extra air that's being trapped. But when they're in the middle of an asthma attack, it could look similar to this because of all that air that's being trapped for them. Chad, you're looking like you have a question, maybe.
Is that the rib cage or not the spine? The image down where there's like the.
Yeah, there's the spine. There's the spine.
Okay, so what's right below that? The other. To go in a little bit. No. Oh.
Heart.
That right there. What is that?
That could be the aorta going down, coming off the heart.
Okay.
But
That's big.
could be.
That's big.
Could be.
So, it's kyphosis, right, is the one that's like where the
The
top part of it?
hump back. But that's looking at the spine. That's looking at the spine.
So, but is kyphosis is just genetic? Or if somebody has COPD, they can develop kyphosis?
Not necessarily. Not necessarily. That's something could be totally unrelated.
Sure, it's horrible
But
posture.
this is just, yeah, probably maybe poor posture and things like of that.
Well,
Again,
because
it
I'm
could
just
be.
looking at like the curve of like the spine and stuff like that, so it just seems like.
But
it
again,
just seems excessive.
partly because of all that trapped air. And this is something that doesn't happen overnight. It builds up over time as far as that increased AP diameter. Now I do say a chest x-ray is neither sensitive nor specific for COPD. I could look at this image and say that looks like a COPD patient, but I cannot diagnose it based on the image alone. If I'm suspicious, everything else kind of points to COPD, and the image looks like COPD, okay, that's gonna help me with the diagnosis. But you can't look at the x-ray alone. Like you could look at a pneumothorax and, yeah, that's a pneumothorax, there's no question on that. Or atelectasis, that's atelectasis. But this doesn't necessarily mean that that's a COPD patient. We could see a cystic fibrosis patient have a very similar appearing x-ray, because they hyperinflate as well, just like the emphysema patient, just like the COPD patient, just like the asthma patient.
Will the extra mucus show in the x-ray?
It could, if it's significant enough. If it's large, if the amount that's being produced is large enough, it could. All right, so we've talked about this in the past. Sorry. It's funny, I have a second year student texting me, and it's about an x-ray image.
That's me.
Oh, is it you?
Yeah.
Oh, okay, I'm sorry. I'll get there, sorry. I just assumed we were all together, it must have been a second year student. All right, so intubation, to make sure we have proper placement of that endotracheal tube. So again, the ET tube does have that thin radio-opaque line that will show up on x-ray so we can see its proper positioning. Make sure you remember where the carina, again, these projections are no good. All right, I'm right at the carina here, okay? That's the carina right here. If you have the image in front of you, it looks much better on your device than it does on my projection. So there's the carina, there's the right, there's the left, obviously there's the trachea. No endotracheal tube right now.
I was about to say,
Oh,
you must be
that was
seeing
so
something I'm not.
Yeah, you guys are looking really hard for the
I was
ET
too,
tube.
I'm like,
It is
where?
not there.
Yeah.
It is not there.
I'm like, I am not gonna be good at this.
How about now?
There you go.
Okay,
Nice.
and this is a little over the top penetration. Usually you don't see both sides of the tube. Usually you just see a single line, but you happen to actually see the entire tube going down. Again, if you could find where the carina is and see if it is approximately 3 to 5 centimeters above the carina. Again, we need it for proper placement of the endotracheal tube. Again, if I'm gonna superimpose and doctor that image a little bit, there we see a very clear example of where the tube is in relationship to the carina. Again, this is not what you would see imaging-wise, strictly for us. You would see this, and maybe even not as good of an appearance of the tube, but that's what you would see to determine how close is it, again, to the carina. The carina.
Yeah, you're pointing at it.
Right about there, right about there.
Right before the bifurcation.
Right before the split, right here,
But how do you know that?
because I can see it. Fourth or fifth intercostal space, lower level of the aortic knob, is the anatomical definition for where the carina
I was
is. So
just
you
gonna
can
say,
definitely
fourth and
kind of
fifth.
narrow it
Yeah.
down instead of going, is it up here? Is it down here? I don't. Fourth or fifth intercostal space, this is the aortic knob. It's somewhere in that vicinity. At least that kind of narrows your vision to a more general area than sometimes just kind of looking all over the place.
Were you talking about the aortic notch?
Mhm.
Okay. You said knob. I was like, huh?
Notch, knob, it goes by both.
Oh,
Goes by
okay.
both. And generally, you don't see the cuff on an x-ray. Again, this doctored image really kind of goes over the top to kind of show where it is. But again, remember, 3 to 5 centimeters above the carina, and we've talked about those numbers in the past. Again, please don't forget those numbers. Those are super important.
What were those numbers again?
I forgot. To be honest, that's a board exam question. The second year students are probably sick of me saying that number, but again, it's something that just has to become second nature, back of your hand type stuff, that you know exactly where it is. What about this one, this x-ray? Again, if you can follow the radio-opaque line and follow it all the way down.
Which one into the?
It's
Oh,
going into
I'm
the.
seeing something's right here, but it's still continuing to go past that something, right?
It's went into
Isn't
the
that
main
the
stem.
carina here? Carina right there where my marker is. There's the left, there's the right, where the tube is continuing to pass into. And notice, it's inflating the right side. And what's
Nothing.
happening to this poor left side? Nothing. They're not getting any air. Again, remember, when you auscultate and listen, what are you going to hear here? Breath sounds. What are you going to hear here? Nothing, or diminished, severely diminished breath sounds. Not hearing any airflow on that side. Sure.
That's it right there? Gotcha.
Yes, yes.
So do you just count when you look at something, or now you can just like look at it?
You'll be able to look at it in time. And again, part of it does have to do with the quality of the x-ray. There's going to be some x-ray where the quality is extremely poor, the image is overexposed or underexposed. Again, those poor quality images kind of have to say, well, we're gonna need to look at another one, a better image, to be able to identify things, identify structures. All right, so CT scanning, computed tomography. All right, so this is imaging, but at a much better quality. But I will say with this better quality means there's an increase in exposure to radiation. So don't think that this would ever replace an X-ray, because an X-ray image, exposure to radiation is very, very low. Very, very low. CT scanning, greater exposure to that radiation energy. So a patient could have a standard chest X-ray where something is a little suspicious, and they may say, okay, let's get a CT scan, because they want a better, clear image of whatever they're suspicious about. That's okay. That happens. And it could be nothing. It could be something that they were able to recognize on the X-ray, but they needed a better, higher quality image, so that's why they ordered the CT scanning. Remember I said before, standard chest X-ray shows a two-dimensional image picture of a three-dimensional object. With CT scanning, you can get that 3D imaging. Instead of seeing the entire lung at one time, trying to identify what you're seeing, CT scanning can give you sliced images, extremely small, 1 to 2 millimeters in size. So you can see very specific, very tight, very close areas. You can see what the top portion of the lung looks like, the middle portion, the bottom portion of the lung, in these very thin slices. Again, we mentioned the drawback here about significant amount of radiation compared to a standard chest X-ray. You can see many different things. So reasons for CT imaging: lung tumors, better clear imaging, really see exactly where that tumor or those tumor marker or edges are. A pulmonary embolism, a blood clot, that will appear. Blood clots, pulmonary embolisms, you really can't see on a chest X-ray, but you can see them on a CT image. You can see those clots inside the left pulmonary artery, for example. Chronic interstitial lung disease, pneumonias, occupational lung diseases, folks that work in coal mines, work with asbestos, work with other chemicals, those things could appear. Not that they can't appear on an X-ray, but again, the quality is going to be much better with a CT image. COPD, of course, the emphysematous changes that could occur.
So the clot's is gonna show white, just like it is up there?
No, it'll appear darker in color. They can actually do, again, don't want to get too much into it because we're going to talk about that next semester when we talk about pulmonary embolisms. But you can actually see the clot, the length of the clot, where exactly that clot goes.
Can all of these show up on a normal X-ray or only some of them?
Some of them. So for example, like a PE, you really can't see the PE. You really can't see the clot on an X-ray. There's some things that a patient with a pulmonary embolism, the chest X-ray may show certain things, but definitely it's not going to show the clot, which that's what you ultimately need to identify. So a CT image for a patient who has a PE, that's one of the gold standards, to have a CT scan, because you can't see it on a standard regular chest X-ray. I think here's just another image, another slice, where a couple of these black arrows are pointing to. I know it's kind of hard to see. Here's some emphysematous changes seen with a COPD patient or emphysema patient. Again, we'll talk about what occurs in those diseases later, but you can lose the alveolar wall. You could lose the associated pulmonary capillaries with those alveolar walls. Really, it's destruction of the lung parenchyma, the lung tissue. Again, the part that's supposed to participate in gas exchange. No wonder those patients become so short of breath. Is there any way to correct this? Not really. Again, we encourage them to stop the stuff that's causing this in the first place. And again, without getting too much into it, but I think it's obvious. What's the number one cause of COPD/emphysema? Okay, so the damage has been done. Again, it's hard to reverse that damage.
When we were at U of critical in the ICU,
Mhm.
because she had pulmonary hypertension.
Okay.
She was in a nursing facility, and then she decided to take off her oxygen to go smoke a cigarette. And, yeah, and then her saturation went to sixties.
Mhm.
But
very
then they
notorious
said
amongst
that they don't
us.
think that she will make it.
Yeah.
And I was like, yeah.
Yeah, but, so, whatever floor she's on, to walk down to the first floor, to walk outside the building, to walk across the street with everybody else that's across the street smoking a cigarette, yeah.
It's a bad
It's a
addiction.
shame. I'm sorry?
I said it's a bad addiction.
Because
Because my grandfather was in hospice, and up until the moment he was dying, he's like, I want a
Yes.
cigarette.
Yes, it's one,
Didn't care.
nicotine is one of the most addictive chemicals out there. Again, not gonna jump too much into that, because that's a whole nother soapbox lecture coming from me, but we'll hear it when we talk about obstructive lung disease, I can't wait, COPD next semester. Guess what disease we open with?
COPD.
I have the whole break to get ready to talk to you guys about COPD. I get a little bit of you get a little bit of a breather, I get a little bit of a breather, for the holiday break to come back and talk about my personal favorite, COPD. All right, MRI, magnetic resonance imaging. We talked about it just the other day, careful about steel cylinders and our other equipment, our stethoscope, stuff like that. Don't want to go flying through the air. But MRIs, magnetic resonance imaging, does not use radiation. Does not use radiation. So, if you want to lessen exposure to radiation, let's not get an X-ray, let's not get a CT scan. How about an MRI? Again, the quality of the image is very good, probably better even than a CT scan. But what's the drawback?
Metal?
Yeah, okay, well, don't bring anything metal in there. Take off your necklace and your rings and earrings and,
Well, they like an implant.
okay, certain things that may be inside them, metal things that could be inside them, okay, they're not gonna be the best candidates. So yeah, there's gonna be some limitations. Pat, you? Takes them forever to get. So, do you mean schedule, or do you mean once they're in there?
Both of them.
Okay, both. So, MRI imaging, depending what's being imaged. Let's first go there. If it's my hand as opposed to my full body, hand's not gonna take quite as long as if you're scanning my full body or my head or brain or something like that. But when you're in the MRI, you have to stay perfectly still for the time that the imaging is done. Now, on the low end, that could be 15 minutes. You okay being slid into a chamber, surrounded, hearing this hum, constant hum, being in there, and you can't move a muscle as they're scanning for 15 minutes? But it could take up to 2 hours, depending what they're scanning, depending what they're looking at. So part of it, and why you don't see it done too much in respiratory or in pulmonary medicine, is because of what we call motion artifacts. The patient, you're being scanned, you're half hour in, I'm just doing one of these, I'm itching, I just gotta move. You gotta start over, because you please be still. Like, I can't, plus just think about, and I'm not a claustrophobic person, but I think if you put me inside one of those tubes, and it's going on 20 or 30 minutes, thank you, give me some meds, keep me calm. If I fall asleep, I'm likely to start moving, and there's more motion artifact. My uncle, God rest his soul, he was a very claustrophobic person. He breathed, and he was a big man, breathed out inside of an MRI suite. And they're like, you're gonna have to, and he told him, you're gonna find some other way to be able to diagnose me or to scan me, because I cannot be in there this long and not move. That's the biggest problem, or limitation, I guess I should say, with an MRI. Image quality is great, but the patient has to be perfectly still. And again, you're not still for X-ray. Shooting, take a deep breath and hold it. Click, okay, done. No, you're in there for a whole lot longer and you can't move a muscle.
Yeah, when I had to get my ankle looked at, like it took like 45 minutes the first time, and then they're going through the headphones, like they had like a microphone that was like,
please stay still. Right.
And then they finish and out.
And I'm sure the people that work in there are like, oh my gosh, stop moving, dude.
And then I had to go back in the second time anyway.
Yeah, right. But, you know, for example, maybe a woman who's pregnant, to avoid the fetus exposure to radiation, if we can get a decent quality image that way, maybe an MRI would be appropriate. Now, sometimes with MRIs, they do have to inject certain chemicals and certain dyes. Now, when I say contrast, when I say fetus, so that then may change for a pregnant woman because of the dye. Maybe, okay, we can't give this dye to this pregnant female because of the damage potentially to the fetus. But again, something else to consider, Ultrasound. Here's really the new way when it comes to ultrasound of the chest. Ultrasound's been around a long time, right? Ultrasound, scanning images of mom and baby, stuff like that, great. Ultrasound is using sound waves, considered harmless to humans. And so that's why, you know, moms having ultrasounds all the time, again, perfectly safe to the babies, perfectly safe to the child. Ultrasound could be extremely small, portable, brought right there to the bedside to look at different things. Could be used for several things applicable to the chest or to pulmonary medicine. Guidance of a needle or catheter placement during thoracentesis, when they stick a needle into the chest to drain maybe pleural fluid. During a chest tube insertion or a central line placement, a fancy IV going down close and into the heart. Maybe even stuff that appears on x-ray that you want to see some different clarification of. You can possibly use ultrasound. You can see a pleural effusion. You could see a pneumothorax. Even endotracheal tube placement is possible with ultrasound. So it's just amazing that that technology can work. Of course, it's going to look different than an x-ray or CT scan. Heart function. Echocardiography, to see the structure of the heart, to see how the valves are working. Blood flow even. They can even add color to this and you can see the blood flow moving through the heart. You can see the valves opening and closing and blood flow going out and maybe even seeing some blood flow backing up, regurgitation where the valve may be damaged. Fluoroscopy. So this is an X-ray imaging technique that is live action. Instead of an X-ray that the only exposure to the X-ray radiation is when that button's pressed, this is continuous X-ray imaging. It's constantly occurring. So there is no snap a picture and no more radiation. This is continuous exposure to radiation. You can see it in the cardiac catheterization labs. For us, you can even see it during bronchoscopy. So as they're putting that scope down through the lung to look at whatever they're looking at or to get whatever they're trying to get, that could be done during bronchoscopy. A fluoroscopy technique, which is continuous X-ray imaging. I don't know if you can tell what these people are kind of wearing here. Safety precaution, these lead vests to try to lessen the exposure they're getting to radiation.
30-minute back pain and on.
Speaking of radiation safety, again, don't worry about the numbers because I know I'm not going to ask anything specific to these numbers and the numbers are kind of pointless to us, but I just wanted to show what a standard routine chest x-ray exposure is versus what's considered an annual exposure that would be considered something dangerous. Don't worry about the numbers. I'm not going to quiz or test you guys on any of those numbers. But if we're going to be exposed to radiation, continuous exposure to radiation. I'm working in the bronchoscopy lab today. We have 4 cases, everyone's using fluoro. We have 4 cases tomorrow, 4 cases the next day, 5 cases the day after that, all using fluoro. How much exposure am I getting exposed to? Or I'm going to be taking my patient to CT scanning multiple times, multiple exposures. Again, those have those fancier imaging, not MRI, because MRI is not exposure to radiation, but some of those fancier imaging techniques, some we haven't even talked about yet, like PET scanning, positron emission tomography, some of those fancier scannings that you may see maybe with lung cancer patients. Again, greater exposure to radiation. So it may be important to be obviously protected during those procedures. And there's gonna be times as a respiratory therapist, and there's maybe a reason I didn't work in those areas because I didn't want to get all that exposure. But as respiratory therapists working in a hospital setting, there could be times we have to go with that patient to be there. You know, and I said this before, anytime our mechanically ventilated patients go somewhere, nobody's gonna run that ventilator but the respiratory therapist. So it's, well, who's taking care of this patient today? Oh, that's me. Okay, well, I'm going on the road trip with this patient, going to imaging, going to x-ray. Jeremy, you and I are covering the ICU today. You watch the other patients that are mine. He has his own, but he's gonna go ahead and keep an eye on the others, since I'm gonna be off the floor, out of the unit. Again, that's how we're all gonna be, because there's gonna be the same time the other therapist in the unit's gonna be off the floor, and you gotta kind of help them cover their patients for a while. But fluoro, God bless you, definitely carries lots of potential exposure, because again, it's continuous x-ray imaging. So what's the individual gonna wear? Lead vest. Notice this is just not covering the chest, it's covering the waist, covering the groin, front and back. All right, because that scatter radiation can go everywhere. All right, so front and back, including the neck, including the eyes. Again, you could still absorb that radiation there. So, occupational exposure to ionizing radiation can be reduced by implementing 3 particular principles of protection. Time, limit the exposure. The less exposure we get, the better it's going to be for us, the less exposure to radiation. Distance, the further away we can get from the radiation, the less exposure we're going to get. If we double the distance, that reduces the exposure by a quarter, by 25%. Shielding, that's where we're using those protected lead aprons, neck pieces, etc. Radiation safety goggles. Again, you look quite cute and attractive when you're all loaded up here. And do you think lead is light?
No.
It's heavy. It's heavy. So I can only empathize with the individuals that work in that environment that have to wear that stuff 24/7, right? Cath labs, things like that, where they're wearing that stuff all the time. You know, more power to them. I guess when you're in there, you can do a couple of knee bends and you get your workout doing some squats while you're in there. I say that jokingly. I wouldn't want to be stuck having to wear that all the time. But there's going to be times we will go to the cath lab with our vent patient, and we're going to have to be protected. So make sure we get the stuff. And again, I would rely on the staff that's there to make sure they give me the proper protection. And if you notice, well, I'm wearing the lead apron. Everybody else has that thyroid protection on the neck, but nobody handed me anything. Hey, can I get the piece for the neck too? You know, make
It's
sure.
usually, I mean, it's 2 different parts, but they're usually like clipped together.
And they can be, but again, you're gonna probably get the lead apron that nobody else uses. They save for the extra person that shows up in there, and that's the one we end up getting, right? But always make sure you have the complete protection.
And no one
They-
wants to share their connect color with their
They
phone.
may also, again, depending how frequently we get exposed as respiratory therapists, definitely the staff in there wears these, but these dosimeters to measure the exposure to radiation. That, you know, they measure it over a month's time. And then they collect their badges, basically, without your picture, little badges, and they can analyze to see how much exposure you've had over that month's time. If we're working respiratory, we may or may not have to wear those, but it just depends the environment we work in and how often we're down there exposed to radiation. If you're in your event patient's room, x-ray comes in to do a portable scan, you know, step out for a few minutes. I'll go check on another patient. I still got other stuff to do in that patient room, but I'll step out. I'm not going to be in there when they're shooting that image. Even though the standard chest x-ray exposure to radiation is still very low, it just builds up over time. So why risk it? Why stay in that room? So I would step out and go to some other room temporarily, because again, for x-ray image, it really is click and the image is over.
Do they get a differential because of the hazard of working around with radiation?
That's a good question. That's a good question. Generally, no.
No?
Generally, no. But I'm with you. Hazard pay, right?
There you go.
A little more money if I'm going to be exposed to this. Special consideration needs to be taken with pregnant women when it comes to exposure to radiation. Now, I will say this, kind of last little bullet point here, but does the benefit of the scan outweigh the risk of being exposed to radiation? If the answer is yes, then they should have that scan. Okay? If the benefit outweighs the risk. But if the benefit doesn't outweigh the risk, then no, find another method to do the imaging. Maybe MRI can be done. Maybe something as simple as an ultrasound. Or even, I know it's exposure to radiation, but just the standard chest x-ray. Again, less potential exposure. As a healthcare worker, ladies who become pregnant, why? Why even risk it? Why even risk it going into those environments? There generally is enough staff that you can say, hey John, if you come and take my patient down, I'll knock out 3 of your treatments or your treatments that are up on the 4th floor. You know what I'm gonna say to that? Oh yeah, you go take care of those treatments, those nuts on the 4th floor. I didn't mean that really. Those crazy people on the 4th floor, and I'll go with your patient down to imaging. Okay, again, in the department, we should be part of a team. And you guys probably have seen this already. There's team players and there's not such team players. But I think we all need to be team players to be able to get along. And you scratch my back, I'll return the favor one day and scratch your back, and we can all make this a much better experience. Questions? Questions? Short, sweet? I think there's only one more chapter after we take the next in this class.
What would you want to, or what kind of scan would you do for like, to assess like the function?
The function of the lung?
Yeah.
Wouldn't
As
have
it's, like,
necessarily,
as it's going.
that would be more of a pulmonary function test, the breathing test, as opposed to just looking at imaging.
Right.
Imaging. Now the imaging can help us with the pulmonary function test, but as far as function goes, that would be the PFT.
Makes sense.
All right, questions. Which of the following tissues will look radiolucent on a chest radiograph? Is that blood, bone, lungs, or liver? Will look radiolucent. Ooh, this must be a tough question. Ah, liver? I should have come up with another one too. Radiolucent means what color? Dark. Dark means? Thank you, air. Where's the air? Okay, this one's an easy question. Get my finger pointing to it. All right, lungs. Lungs. Get it wrong here, you'll get it right on the test, right? That's where it counts, on the test. I had a student one time, we do these questions. He sat close on the front row, always blurted out an answer. Was wrong more than half the time. I felt bad, because the students are like, man, but I don't think he even read the question. I would say, I don't know, he just wanted to be the first one to answer, I guess. I don't know. I eventually had to say, well, calm down, let me finish reading the question. Let's pause for a second or two, let people process what the question is before you blurt out an answer. But he got them all right on the test, and I guess, honestly, that's where it counts. That's where it counts, right? All right, so this one, radiolucent, lungs. I could change that word radiolucent to what? Radio opaque means it's white. Then what would be the answer? Everything but the lungs, right? Everything but the lungs. But what if the lungs was full of pneumonia? That could be radio opaque too. Or the lungs were completely atelectatic, completely collapsed. Well, that could appear radio opaque as well. All right, next question. B. What breathing instruction is a patient given immediately before an anterior posterior or posterior anterior chest radiograph? A, breathe normally. B, breathe deeply. C, exhale completely. Or D, don't worry about breathing, it will not affect this x-ray.
You know, he's right.
He was right. Sometimes guessing is luck. All right, so breathe deeply. Breathe deeply with and hold. A breath hold. A breath hold. It's like the MDI, DPI, right? Take a deep breath in, hold it. All right, so same thing with the image.
Should I go 2 for 2? 2 for 2, let's go.
He don't get it wrong on the test.
Give me a letter. Give me a letter.
Yeah, do it before you.
That's right. I didn't get, even this one, he didn't have a chance to see it. All right. All right. Which of the following views is most helpful in identifying a small pneumothorax?
Okay,
Expiratory view, AP view, left lateral view, or Jeremy says lateral decubitus view, but I'm not sure about that one. This one is A, an expiratory view. For a small pneumo. And that's okay, we were just guessing anyways. All right, a small pneumo. Now, standard X-ray pneumo probably could be seen, but like I said, if it's very, very small, they may want to have the patient go ahead and exhale all the air in their chest. They can't exhale the pneumo, so that expiratory film will show that air that's trapped in that pleural space.
Alright, I'm going B.
I don't remember. Dang it! I'll go ahead and say you were correct on that one. It is B. All right, everybody okay with those three? All right, so what's going on next week in here? Tuesday, a test. And that will be test number 3. The last test in here for this particular class. We still have one more chapter to discuss.